Thank you. Good morning. My name is Dr. Fatuma Msafiri. I am the project coordinator from Tanzania, and I am here on behalf of the project PI, who was not able to make it today. And I'll be taking you through our project. Our project's name is Optic TB, and I have nothing to disclose. So Optic TB is just the short form of optimizing the implementation and scale up of the WHO treatment decision algorithms for pulmonary TB in children under 10 years of age in Sub-Saharan Africa. And our project is being implemented in 3 countries, in DR Congo, Uganda, and Tanzania. And also we have a leading team from the University of Bergen who's coordinating all the activities that are being done in the 3 countries. As we know that tuberculosis is still an issue in Sub-Saharan Africa, although it's preventable and it has a cure, we still have approximately 1.1 million children who are being diagnosed with TB worldwide each year. And also TB remains to be a leading cause of mortality with over 200,000 deaths annually. And in Sub-Saharan Africa, it's still the same. It's still the leading cause of death among children, accounting for 20% of the global pediatric TB. And we only have 20% of children under 5 who are accurately diagnosed and treated each year. So as 32% shows that we still have an underdiagnosis of the tuberculosis, and also this leads to disease progression and mortality. As you can see in 2021, there was a lot of cases notified in all the 3 countries, but we had a number of children who were not diagnosed. And the leading country with the huge number of children who were not diagnosed were DR Congo, followed by Tanzania, and then followed by Uganda. So why do we have this problem of underdiagnosis? It's due to, as we know, children have very non-specific clinical features compared to adults, but also we have limited access to diagnostic tools, especially in Sub-Saharan Africa, but also the TB score charts that we use to diagnose TB in children have a very low specificity, and they do not integrate variety of diagnostic tools. So that's when the WHO recommended the use of the TDAs to be able to address the diagnostic challenges that we have. These TDAs have, they incorporate molecular diagnostic tools, and they also have a very comprehensive scoring system. And simulatively, it has been shown, the TDAs have shown to be very effective, although we don't have, we have very limited information on the TDAs and how they're going to work in the clinical context. So there is a need to validate these, to validate and standardize the TDAs so that they can be utilized and used in the facilities that we have in Tanzania, Uganda, and Congo. So that's where our project comes in. The aim of our project is to optimize the implementation and scale up of the WHO TDAs for children under 10 in Sub-Saharan Africa. And hypothetically, these TDAs have shown to be superior compared to the standard of care by increasing at least 20% of the TB that is detected and initiation of TB treatment in children below 10 years. And also the TDAs have shown that they have good treatment outcomes, especially in the intervention facilities. So our research objectives, the project objectives, we want to evaluate the effectiveness, the cost effectiveness, the feasibility, and the acceptability of these TDAs on how they're going to help to detect pulmonary TB in children under 10 years. In a nutshell, that is our project. It's a 4 years pragmatic randomized trial, and now we are in the second year of the implementation. The first year of our project was basically to get approvals, to standardize our tools, to orient the government officials on our project. And then we are in the second year of the implementation, whereby we have chosen 120 facilities from Tanzania, Uganda, and DR Congo. And then we have divided these facilities in a ratio 1:1. So the first 60 facilities from all the 3 countries, they are going to continue using the standard of care, just as usual. And the next 60 facilities, we are going to train them on the use of the TDAs. Then we are going to go with all the facilities at least for 1 year. Then after that, we are going to do an interim analysis from all the 120 countries. Then after 1 year, we are going to scale up the TDAs in the remaining 60 facilities that we are using standard of care. Then after that, we are going to do a follow-up at least of 9 months, a follow-up of 6 months. Then after that, in the final year, we are going to do a process evaluation, and we are going to finalize the data, and we are going to come up with a report. So we are able to do all this, and we are continuing to implement our project by comprehensive training programs, whereby we are training all the health workers on the use of the TDAs and treatment. We also have in our project, we have access to, we've given access to PhD students and master's students so that they can work on the project. But also we are doing a lot of workshops and seminars and academic courses to help transfer the knowledge of the TDAs to the healthcare workers, but also ensuring long-term impact through continued support and follow-ups on these training activities. And in conclusion, the optic TB is we are expecting clinical impacts. We are expecting that the TDAs will help to improve case detection, especially in children among children under 10 years, but also the TDAs will enhance treatment outcomes by reducing the TB delays in treatment and improve the treatment success rates. But also, we're expecting that there will be an overall reduction of TB-related morbidity and mortality among children. Economically, the TDAs have shown that they are cost-effective and they are able to be implemented in resource-limited settings. So it means even the places in the rural areas, they are going to be able to implement and adapt the TDAs, but also long-term economic benefits of healthcare systems by reducing the TB burden. And politically, at the end of our project, we are expecting that the findings that we'll get are going to support the changes in the TB, in the national TB programs to incorporate all the TDAs. And also, we are expecting that we will be able to scale up the TDAs across Sub-Saharan Africa. That is contributing to long-term improvements in TB diagnosis and treatment policies. And lastly, I would like to acknowledge the Optic TB team and the Second Innovations for the opportunity, but also special thanks to our sponsors, the EDCTP. Thank you so much.